name is Sachin. I'm one of the nurse practitioner students, and I will be doing an abdominal examination on you today, okay? May I have your first and last name, please?
My first name is Reena, my last name is Singh.
Reena Singh, how old are you?
I'm 29 years old.
Okay. Reena, this video that we're doing will be it will be recorded and published on YouTube. May I have your permission for that?
Okay.
Okay. All right. So I've already washed my hands. Already introduced myself to Reena. So, Sahil, I want you to focus on the abdomen. So I'm going to go ahead and expose the abdomen. Okay. All right. So the first thing is the inspection of the abdomen. So just going to move back a little bit so I can capture the whole thing. Okay. Just move back. Okay. So the first thing, go ahead and just focus here on the abdomen. Okay. So the first thing I'm going to inspect the abdomen for any abnormalities. Okay, which includes any skin rashes, any lesions, any previous surgical scars, which in Reena's case I don't see. Next, I would look at the contour of the abdomen, and to me it appears fairly flat. One of the abnormalities is called protuberant abdomen, where it is protruding up. And then you have a patient that has ascites would have something that is more of a widened, like a bulging flank area, and that is an abnormal finding. In Reena's case, her abdomen looks flat to me. Other things that I would observe for is the color, and the color is normal to race and ethnicity. It's light brown. I don't see any skin discoloration either at all. And I would also inspect for any kind of like peristalsis movement of the abdomen, which may suggest an intestinal obstruction, which in Reena's case I don't see that. The other thing that I would see, visually inspect, would be any kind of obvious lifts or heaves of regions where the abdominal aorta, which begins here at the xiphoid process, it goes down. Then you have the renal artery, which comes on a pair. It is a paired artery that branches off the aorta. It comes across here, and then the aorta bifurcates at the level of the umbilicus into the common iliac artery. The aorta, are you focusing here, Sahil, on the abdomen? I want you to focus on the abdomen, okay? The aorta is more towards the left side of the umbilicus because you have the inferior vena cava, which also is on the right side. So the aorta comes down, it bifurcates into common iliac artery, and then you have the internal iliac artery, which supplies the pelvic area, and then you have the external iliac artery, which goes down and supplies arterial blood to the lower extremities. As soon as it crosses the inguinal ligament, it becomes the femoral artery. So I would observe, inspect for any obvious lifts or heaves at those regions which I have just mentioned. Which in Reena's case, I don't see any abnormalities as far as lifts or heaves at the aorta, renal, bifurcation, iliacs, and at the femoral. I just wanted to mention that Reena here had previously told me that she doesn't want this part exposed a lot for the video. So just wanted to mention that. So my inspection is done now. Now I will go ahead and move on to the auscultation part. And the abdomen, I'll focus right here, sorry. The abdomen is divided into 4 quadrants. You have the right upper quadrant, the left upper quadrant, and left lower quadrant, and then you have the right lower quadrant of the abdomen, okay? So I will auscultate each quadrant. And to truly diagnose a patient with hyperactive bowel sounds, you are supposed to listen to each quadrant for a full 5 minutes. What I expect to hear in a healthy individual with normal active bowel sounds will be about 5 to 32 gurgling sounds per minute, and that's a normal finding. So I'm going to go ahead and listen. So Rena has normal active vowel sounds. Now, while I'm already in the osculatory process, I'm going to go ahead and listen to the aorta, the renal arteries, the bifurcation to the common iliacs, and then the femoral artery with the bell, with the diaphragm as well as the bell. So we'll go with the diaphragm first. Now with the bell. Okay. So I don't hear what abnormal finding will be a bruit. And in Rena's case, all those anatomical landmarks which I have mentioned, I do not hear any bruit to suggest any abnormality there. Now, since we're still in the auscultation part, um, uh, have the liver in the right upper quadrant. Liver is covered by a fibrous layer called Gibson capsule. And when a liver, let's say, has a tumor or a liver infarction, then there's a possibility that you may also hear a friction rub. And also a spleen, which is in the left upper quadrant. And you can also hear splenic rub, splenic friction rub if you have for instance, splenic laceration, which results in the pooling of blood around the spleen. So I'm going to go ahead and listen for any kind of friction rub of the liver first. So I do not hear any friction rub on either over the liver or the spleen. I am done with my auscultation. Now I'll go ahead and do the percussion. The percussion will be of the all four quadrants initially, and what I'm expecting to hear is a timpani sound. So we'll go ahead and do that now. So. Okay, so I heard timpani sounds in all four quadrants. Now I will go ahead and percuss the organs. We'll start with the liver first. So I will mark the lower border of the liver, and I will start the percussion a little bit lower. In case in patients that have an enlarged liver, the border may extend a little bit more down the subcostal region. So I'll go ahead and percuss from a little bit further down here, which I'm expecting to hear timpani sounds, and I will percuss up till I start hearing dull sounds. Are you focusing here, Sam? Okay. And then I will mark that as the lower border of the liver, and then I will go up to the right chest area, and I will percuss from the timpani sounds, which actually is going to be a resonant sound, which will be from the lungs, and I will percuss it down till I hear a dull sound, and then that will be the upper border of the liver. So here we go. Just lift your breast up for me. Let me try that here. So it's about that. That looks approximately 7 centimeters to me, which is a normal finding of the liver. Normally you won't be able to percuss the spleen unless if it is enlarged. So what I'll do is I'll percuss it right at about the 12th rib, 11th intercostal space area, and I'm expecting to hear timpani sounds, because usually a percussion of the splenic area would reveal a timpani sound, unless if the spleen is enlarged, and you'll hear the dull sounds. Okay, so that's timpani sounds, percussion sounds, and now we'll have Rena taking a deep breath and hold it, and that, as the diaphragm descends down, that will, if the spleen is enlarged, we'll kind of push the spleen down a little bit, and then I'll percuss again to see if I do hear any dullness or not. Go ahead and take a deep breath, Rena, and hold it. Okay, good. You can breathe now. Okay, so I still hear a timpani sound, actually. I don't hear the dullness at all. The other organ is the bladder. Once again, expecting if the bladder is empty to hear a timpani sound, or if the bladder is full, then I'm expecting to hear a dull sound. So I'll go ahead and demonstrate that. Bladder is more suprapubic region, so I'll go ahead and percuss that now. Okay, so definitely dull sound there for the bladder. I am now. I have completed my percussion, and now I will go ahead and move into the palpation now. So initially, we'll start off with light palpation of all 4 quadrants, and what I'm feeling for is any enlargement of the organs, or feeling for any mass or anything like that. So go ahead and focus right here. So I'm going to start with just a light palpation. Any pain at all, Rena? No? Go ahead, cross over there. Thank you. Alright. So, light palpation, I did not feel any mass or organ enlargement of the organs at all. I'll go ahead and now do the deep palpation. Okay, any pain at all? No, okay. Usually I would go a little bit more deeper than that, but she just had her dinner, so I don't want to go too deep and upset her stomach. But once again, with deep palpation, what I'm feeling for is just the organs that's just underneath, for any enlargement or any mass, which I did not feel in Rena's case. On the right upper quadrant, you have the liver, gallbladder. You have the little bit portion of the ascending colon and the duodenum. On the left side, you have the spleen. On the right side, I'm sorry, you have the gallbladder as well. On the left side, you have the spleen. You have the transverse colon, a little bit of the descending there. And then the left lower quadrant, you have the sigmoid colon and then the descending colon. And on the right lower quadrant, you have the appendix, the ileum, the cecum, and the ascending colon here on the right lower side. So now we're still in the deep palpation, and now what I will do is I will feel Rena's liver, the lower border of her liver. Of her liver. Okay, so I want you to focus here. Okay. All right. So we're gonna go this way, and I'm going to have her take a deep breath in as I do that. So Rena, go ahead and take a deep breath in and out. Okay. Okay, I feel that there now. So I did feel the lower border of the liver, and it feels smooth to me. I felt it. It's approximately maybe 1 centimeter below the subcostal uh, of the subcostal region here. The other way is the hooking method, and then what I'll do is I will hook on to the subcostal rib here, and I'll have Rena taking a deep breath. Okay, all right. And I do feel that liver tapping on my fingers, and it feels smooth to me as she did that. Now I'll go ahead and palpate in the spleen region. Normally, won't be able to palpate the spleen unless if it is enlarged. So what I'll have Rena do is actually turn on her left side, so I can feel that spleen. So if you want to turn a little bit this way, okay, okay, that's the breath. Right. Okay, taking a deep breath. Okay, all right. You can go ahead and turn it back now. So I'm not able to appreciate the spleen at all on that side there. Now we'll shift our focus to the right lower quadrant where the appendix is at, and I will do. So before I move on to the right lower quadrant of her appendix, what I will do right now is to do the test for the ascites. Ascites is a collection of fluids in the peritoneum, and usually that occurs as a result of liver failure, an accumulation of fluids. With a patient that has ascites, normal finding will be tympany sounds on the top, and then as you go down in the flank region, because of the collection of the fluids, because of gravity, then you'd expect to hear dull percussion, dull sounds, and that would be a positive finding for ascites. So, and also it will bulge out more if the patient has ascites. So I hear the tympany sounds in the middle, and as I go down, I do hear the dull sounds, but and what I'm going to show you now is called shifting dullness test. And what that involves is Rena's going to turn onto her right side, and shifting dullness means that if she had ascites, when she turns, the fluid would gravitate down to her right lower side because of gravity. And as I percuss, the dullness will resolve on this side, and the dullness will become more prominent on this side here. So Rena, go ahead and turn it onto your left side. I'm sorry, onto your right side. No, onto your right side. Yeah. All the way. Okay. All right. So what the shifting dullness means is, so when she was laying on her back, I percussed it and it was dull over here. Now if she would have ascites, and when she turned, the fluid would gravitate down to the right side because of gravity. And now if I were to percuss, will be more tympany sounds here, and as I go down, the dullness will become more pronounced, and that is a positive finding of ascites. Okay. So the dullness is still there, like when she was laying on her back. So that's a negative finding. I'll go ahead and turn on your back. Okay. So while we're still palpating, and before I go into the palpation of the right lower quadrant, I just want to also palpate the aorta, which comes down. And what I'm feeling for, so let me make sure you grab me, catch me here, okay, is the aortic pulsations. Now I will palpate the renal arteries on both sides as a paired branch. I'll palpate the rest of the aorta. That one is a little bit difficult for me to. I don't feel any pulsation there. I do feel the aortic pulsation much higher, right below the xiphoid process. So I do feel the aortic pulsations there. And then the common iliac. Okay, and now I will feel for her femoral pulse. Okay. You're getting everything? So? Okay. So the aorta, I felt a pulse, but it was pulsating. It wasn't expanding. It wasn't like bulging or expanding out. It was more pulsating. If there was an aneurysm, there will be more of a bulging pulsation versus what I just felt right now. And I don't feel anything at the renal artery or at the iliacs. The bilateral femoral pulses are 2+, which is a normal expected finding. 2 out of 4. Now I would go ahead and do the couple of tests for the appendicitis. So the first test is called rebound tenderness, and first I have to find the McBurney's point. So to find that, what I have to do is first find the anterior iliac spine, anterior superior iliac spine, which is right over here, and the umbilicus, and it's about 1/3 way up from the anterior superior iliac spine. So about 1/3 up. That will be the McBurney's point there. And I'm going to press down. I'm going to press down, and I'm going to let it go. Okay. So did you have more pain when I let it go? Okay. So that's a negative rebound tenderness. If she would have had more pain with me letting go all of a sudden, there will be a positive rebound tenderness and a highly it will be indicative of inflammation of the appendix and or peritoneal inflammation. The next sign is called Rovsik sign, and what that involves is me pressing down on her left lower quadrant of the abdomen. And a positive Rovsik sign is if I were to press down on the left side, she would feel the pain on the right side. Are you feeling any pain at all, Rena, on the right side? No? Okay. So that's a negative Rovsik sign. And why that is so, if a patient has appendicitis, is when I press down on the left lower quadrant, it tenses the fascia. And when that happens, and if the appendix is inflamed and or has peritoneal inflammation, the tensing of the fascia would irritate the appendix, and the patient would feel pain, and that is called a positive. That will be a positive Rovsik sign and a indication of appendicitis. The next sign is called obturator sign, and I'm going to do it on the right side because the appendix is on the right side. And what I'm going to do is I'm going to flex her knee and a hip, okay, and I'm going to internally rotate. Okay, are you getting that, Sam? Okay, so I'm going to internally rotate her hip. Are you having any pain right there, Rena, at all? Okay, all right. So that is a negative obturator sign. And so there's an obturator muscle. It's on the right side of the appendix. And when I flex the knee and the hip, and when I internally rotated the hip, that obturator muscle gets stretched. And if the patient had an inflamed appendix or peritoneal irritation on that side, then the patient will have a positive obturator sign and a likelihood that the patient may have appendicitis. In Rena's case, that is a negative finding. The last sign is called psoas muscle sign. And the way I have seen that happen is I would have her turn on her left side. So go ahead and turn, Rena. Okay. And now I'm going to move back a little bit so I can just grab the whole thing. Okay. So what I'm going to have her do is I'm going to hyperextend. So you're going to go ahead and turn. Keep on. No, you're going to turn that way. I'm going to hyperextend her leg. Are you having more pain there, Rena?
No.
Right. No pain at all.
Mm-mm.
Okay. Good. All right. So when I hyperextend her leg, it stretches the psoas muscle, which iliopsoas muscle originates from the spine and comes down, attaches to the hip region. So when I hyperextend a leg, it stretches the psoas muscle. And if Rena had an inflamed appendix or peritoneal inflammation with the stretching of the psoas muscle, she would have more pain. And once again, high likelihood that she may have appendicitis. In Rena's case, that's a negative finding. All right, Rena, go ahead and you can turn back now. One last test and we'll be done. I'm going to have Rena just sit up for me. Okay. And what I'm going to check for is called CVA tenderness. Sarah, do you want to come this way?
Yeah.
Or Rena, if you want to turn a little bit. Okay. Yep, let's go right there. So what CVA tenderness is, if I were to place my hand here, and it's the level of the kidney, and CVA is costovertebral angle. So lower costal vertebral be right there, and let me know if you're having any pain. Any pain?
No.
No. Okay. We can do it both sides. Any pain?
No.
Okay. All right. You can go ahead and lay down. So the kidneys have capsules around them, and when a patient has inflammation, such as in pyelonephritis, when the kidneys get inflamed, those patients will most likely have a positive CVA tenderness. When you do that, they will have pain because with pyelonephritis, the kidneys get inflamed, and with the capsule on it, it gets just irritated. So I'm done with my assessment now. And do you have any questions for me, Rena, at all?
No.
No? Okay.
Thank you.
All right. Thank you so much. You can go ahead and stop it now.